So I'm going to be speaking to you about primary care networks. So first off, we'll be speaking about the funding for the networks and the additional roles reimbursement and the surplus that is generated potentially within the primary care network, and how that is supposed to be treated within the accounts. And then we're going to be moving on and looking at the incorporation or potential for incorporation for primary care networks. So at the moment, we are moving into the third year of the PCN enhanced service, and we're going to be seeing a further expansion of the additional roles reimbursement and increased funding. And hopefully the PCNs are going to have an opportunity to actually realise, their ambitions over the next year, because certainly the last 2 years have been very challenging for the PCNs. So within the first year of the enhanced service, practices were given a very limited time to organise themselves into PCNs. I know recruitment was often a challenge, and many PCNs had a surplus as the £1.50 per head funding hadn't been spent. The last 12 months have been spent dealing with the challenges of COVID and the rollout of the vaccination programme. So you've all been incredibly busy within your networks. So what funding have we got then for the next 12 months? So we still have our core funding. That remains at £1.50 per registered patient. We have the clinical director funding. That's just over 73 pence per registered patient. Now, technically the clinical director funding is paid depending on, the baseline is 0.25 whole-time equivalents for a PCN with a 50,000 patient list size. The whole-time equivalent funding is £142,422. But as I said on this slide, it works out for you, if you're looking at your funding, at just over 73 pence per registered patient. We then have the extended hours funding. That remains at £1.44 per registered patient. We've got the care home premium. So that is paid at £120 per bed, and that is based on the CQC data on care home beds. Now, the care home premium, there were payments that started to go to practices from October 2020, so for 6 months up to the 31st of March. That was paid at £120 per bed, i.e. 1/2 of the annual funding. And then we come into the area where is probably the most significant level of funding for the PCNs, which is the additional roles reimbursement. Now, if you remember, in the first year, you were paid for specific roles as maximum. So you could have a social prescriber and a clinical pharmacist. And then from 2020 and for this year, you are paid per weighted patient an amount up to the maximum, and you can choose which staff mix that you want to have. Now, if you are a 50,000 weighted patient PCN, this funding could be equivalent to about £615,700 per annum if you take the maximum for that funding. So once you add all of this funding together, if we exclude the care home premium element from this, if you had a PCN of a list size of about 50,000, your turnover and your income could be in the region of about £800,000 for the year. So a significant amount of funding that you've got there. So if we have look in a little bit more detail about the additional roles reimbursement that we've got. So as I said, it's paid on a capitation basis, and it's going to be up to the PCN as to what roles you are going to fill. Now, so each practice will need to complete and return to the Commissioner a workforce plan, which is going to provide details of how you plan to spend that money, and that needs to go to the Commissioner by the 31st of August 2021. At the same time, you need to be providing indicative intentions of how you are going to spend the money up to the 2023-24 year. That needs to go to the Commissioner by the 31st of October 2021. By the end of September, the Commissioner has to agree with the PCN the funding that is going to be used. And if there is any gap between the funding that you want to use and the maximum that you could claim under the additional roles reimbursement, that is known as the unclaimed funding. And once that level of funding has been agreed, the PCN cannot claw any of that back. They no longer have the right to claim that money. And the Commissioner can then give the other PCNs within their boundary an opportunity to bid for that money. So it may be that PCNs want to be, look very carefully about what roles that you want to be fulfilling. Now, the PCN will receive 100% funding for any roles that are recruited via the network contracts, the additional roles reimbursement, subject to maximum amounts per role detailed in the enhanced service specification. And we've got details of those maximum amounts to be reimbursed on the next couple of slides. So we'll go through that in a little bit more detail. If you remember, in the first year, you could only claim for 100% of the social prescribing cost and all of the other roles. So the clinical pharmacist was just at 70%. If you have a social prescribing service that is going to be subcontracted, then a PCN can claim up to a maximum of £200 a month towards the service, or £2,400 per annum, towards additional costs that are going to be charged by the subcontractor for the provision of the social prescribing service. Now, this is on the condition that the claim does not exceed more than £200 in any month, and the total amount claimed for the social prescriber is less than the maximum amount which is shown on the additional roles reimbursement table. And again, I've said that we will come on to that in a moment. So we've got some additional roles. So we had a number of additional roles added in from April 2020. So over the last year, the PCNs have been able to employ social prescribers, clinical pharmacists, pharmacy technicians, health and wellbeing coaches, care coordinators, physician associates, first contact physiotherapists, dietitians, podiatrists, and occupational therapists. From April 2021, there are going to be 3 additional roles added to this. So we've got paramedics, advanced practitioners, and then the mental health practitioners. So for the mental health practitioners, from April 2021, every primary care network will be entitled to a full-time mental health practitioner, so 37.5 hours per week. For the mental health practitioner, 50% of the funding will come from a mental health provider, and 50% will be funded by the PCN, again, reimbursable from the additional roles reimbursement. If you are a PCN that has a population of more than 100,000 patients, then that entitlement is doubled. So for the current year that we're in, you can have 1 whole-time equivalent, doubled if you are over 100,000. Next year, the number of whole-time equivalents increases to 2. And then for 2023, it'll be 3 whole-time equivalents. And again, the doubling up still applies if you are a PCN with 100,000 patients. The mental health practitioner has to work full-time in the primary care network, even though they are being funded 50% from a mental health provider. And there were some limits on last year for the number of pharmacy technicians and physiotherapists that could be reimbursed. So you were limited to 1 whole-time equivalent of each unless you were 100,000 PCN, in which case you could have had 2. But from April 2021, that limit has actually been removed, so you can have as many as you want within your limits for your additional roles reimbursement. So I've got 2 slides here looking at the additional amounts that can be claimed for the additional roles reimbursement, the maximum amounts. Now, this information, the web link is given at the bottom of the slide, but this is coming from the network contract, the enhanced service specification. So it's based on the agenda for change rates, and it's the weighted average salary for the related agenda for change band plus any associated on costs. Now, within the enhanced service specification, it does also give the maximum reimbursable amounts for inner and outer London, but as none of you are London practices, I've just put the outside London rates on there for you. So you can see, so we've got the clinical pharmacist, so the AFC band 7 to 8A, the maximum reimbursable is 56,829. So that'll be the salary plus your on costs. We've got advanced practitioners. Now they are the higher AFC band. On the next slide down, you will see the lower band AFCs for the reimbursements for those other roles that you've got. So you can see that there's quite a range of the salary reimbursements that we have there. Now I'll just move on to the next slide looking at the other roles. So you can see that we've also got band 7 podiatrists and occupational therapists. So your maximum funding there is 54,841. And then we've also got in at the very bottom there, the mental health practitioners. So that effectively will be your 50% funding that you have from the additional roles reimbursement for that. So you can see that there is, you do have quite a large scope in how you actually want to staff your primary care network that you have there. So we're just going to come on now and have a look at the service specifications that we have. So for 2021 and 22, we have 4 service specifications. So we have our extended hours. So this is something that you've been doing all along. So it was originally brought in from when the PCNs were originally set up. So in the majority of cases, the extended hours income has been passed back through to the individual member practices. I think in the last year, perhaps some of this money actually has not gone through to practice, but has been retained within the PCN to pay for additional costs and supporting for the COVID vaccination programme that you've got. From April next year, so April 2022, also going into the primary care networks is going to be your £6 per patient that is currently funded at a local level for the extended access service. So that will be coming into the primary care networks to provide that service. We also then have the structured medicines and medicines optimization enhanced service specification. So this is where you are identifying patients within the PCN population who would benefit from a review of their medication and the medicines that they have. So this will include patients who are in care homes, anybody who's got complex and problematic polypharmacy, frail patients, and patients who have medication that could be addictive. Another specification that we've got this year is for the early cancer diagnosis. So this is to reviewing the referral practice for suspected cancers. So this is going to include recurrent cancers and PCNs will also be expected to contribute to improving the local update of the National Cancer Screening Programme. And then we've got the social prescribing. And again, obviously the social prescribing is something that you have been involved with from the very start for the primary care networks. Now, because of the late setting up of it, not every PCN may necessarily have been able to employ a social prescriber, but this is something that you should be able to do moving forward. So obviously, as we've mentioned, the PCN can employ a link worker, or as we've previously mentioned, it is possible that you can subcontract the service out for the position for the social prescribing. So those are the service specifications that you've got. Now we've got coming in now quite a large change for you for the PCNs, which is the Investment and Impact Fund. So the Investment and Impact Fund, also known as IIF, was due to start in April 2020, but it was delayed until October due to COVID. The payment for the first 6 months, so the funding for the initial 6-month period up to the end of September, was paid to PCNs instead. So that was paid into the PCN at a flat rate of 27 pence per weighted patient. And this again was to help with COVID and the additional costs that you've got for that and helping to manage it. So for a PCN who had a weighted list size of 50,000 weighted patients, this would equate to about £13,500 of money that was coming in for that 6-month period. Now, the Investment and Impact Fund is effectively a QOF for PCNs. And the overall aim of this, so the points and the indicators that you have that will go into the Investment and Impact Fund are effectively driven by the objectives that were set out in the NHS long-term plan and the GP contract agreements. And we're going to have a bit of a phased approach for new indicators going forwards. So as I said, it's going to be a significant amount of funding for PCNs. So in 2021, that funding was worth £24.25 million. And then that's going to increase up to 150 million in 21-22. And then that will go up further, so increase further to 225 million for 2022. And then actually in the final year that we have it, the Investment and Impact funding is going to be worth about £300 million on a national basis. So it's a huge amount of money that is actually available out for that. Now, I said that the Investment and Impact Fund started within October 2020, so it's the period that has just gone. Now, for that year, you had 194 points that were available, and each point was worth £111. Now, in the same way that you have for the QOF within the practice, those points are adjusted for the PCN list size, and that is compared to the national average list size as it is for that you have on an individual basis for your QOF, and it is also adjusted for disease prevalence. So the amount of points that you may get may be more or less than £111 depending on your list size and the prevalence within the PCN member practice. And each indicator had an upper and a lower performance threshold for each indicator. So if you achieved the performance was above the higher threshold, then you got all the points for the IIF. If your performance was below the lower threshold, there was no payment at all. And then if you managed to achieve somewhere in between those two thresholds, then you got some level of points that would be applied, and that would be based on a formula that is put into the enhanced service. And for 2020-21, there's only an achievement payment that is going to be received. The important thing as well for the investment and impact fund is it is QOF, you're getting a QOF type income, you are getting additional funding for it, and it is significant additional funding. It is not designed to be providing additional profits in for primary care networks and flowing through to GP practices. So the PCN has to commit in writing to the Commissioner that the achievement money will be invested into additional workforce and or primary medical services. So that investment and impact fund money has to be spent somehow. Okay, so need to be thinking about how you are going to be using that money going forwards. So the points that we had for 2020 and 21, so I said that there were 194 in total. So that breaks down to 72 points for the number of patients who were over 65 and received a flu vaccine between October, obviously, and March 2021. They are also including anybody who had a flu vaccine in September. So you can include the people who had flu vaccines in September within that to be able to get the points that you had. There were 47 points for the percentage of patients who are on your learning disability register, aged over 14, who had an annual learning disability health check. And this is paid as a supplement to the £140 per health check, which go into the individual practices. There are 25 points for the percentage of patients referred for social prescribing. And within this, so when you're counting your number of patients, you can include the referrals that were made between the 1st of April and the 30th of September within those numbers when you're calculating your percentage. So it's giving you that option there. And then there were 50 points relating to medicine safety, relating to gastroprotective prescribing. So making sure that it's not causing any issues for gastro problems for the people that you are prescribing your medication to. So that's where we were in the year that is just gone. So what are we looking at going forwards? So for the current year that we are in, we have 225 points available, and each point is worth £200. So and again, as with the other the QOF in the previous year, that is going to be adjusted for list size and for disease prevalence. Now, they've split the points into two different areas. So we have what is known as a binary indicator. So that has a criteria and a set number of points associated with it. If the criteria is met, all of the points are available. If you do not meet the criteria, you get no points. So it is either an on, you achieve it or you don't achieve it. So binary, on or off for those indicators. The standard indicator is probably a bit more as you're used to, so that will have various thresholds associated with it. So again, payment is going to be made depending on the performance compared to upper and lower thresholds and adjusted for prevalence. Now, when you're looking at the formula for what you get for this, there are various terms that they use as to what you are going to get. So they use something like, say your performance is based as the numerator divided by the denominator for that indicator. To translate that into what that means in a practical basis. So if you have the indicator which is regarding flu, for example, then, and the indicator is related to giving patients over 65 a flu vaccine between certain dates, so usually between the 1st of September and the 31st of March. So your denominator will be effectively your cohort. So how many patients do you have in that cohort that can be vaccinated? And the numerator is actually how many people, or the percentage of people within that cohort you have actually managed to vaccinate. So that's the way that they are working it out. And within the indicators, there are going to be effectively like prompts as to about whether they want you to improve performance, whether it's upwards or downwards. So if you're wanting to improve some health outcomes, for example, giving more people flu vaccines, or whether you perhaps want to reduce disease incidence, for example. So you maybe where you're looking at reducing cancer levels or things like that. And the achievement is normally going to be paid on an annual basis by the 31st of July each year. There is one exception to this for the year that we're in, and this is relating to the access area. So this indicator runs from the 1st of April to the 30th of June. And within this, all practices in the network need to have mapped all of their active appointments slots to a new set of national appointment categories. And you also need to make sure that you're complying with some guidance that was issued in August 2020 relating to the recording of the appointments. So that, as I said, is going from April to June this year, and the achievement pay in respect of this is going to be paid as soon after the 30th of June 2021 as is practical. And as I said, as with the investment in impact fund for the previous year, any money again has to be reinvested into the additional workforce. So the enhanced service, the wording for it for this year, where they're saying what it needs to be reinvested in, it says additional workforce, additional primary medical services, and the addition that they have to the wording, it says, and or other areas of investment in a core network practice, for example, equipment or premises. So it looks as if there's a little bit more scope as to how that investment and impact fund money can be spent from the 21-22 contract changes for that. At the moment, the various points and the thresholds have not been announced, the actual individual amounts, but there are effectively two areas that we have. So the first area is to do with the prevention and tackling health inequalities. That is worth 178 points in total. That will cover areas such as the seasonal flu vaccines. So that's going to be covering your over 65s, the 18 to 64 in a clinical at-risk group, children who are 2 to 3 years old. It will also then cover things like the learning disabilities health checks and the health action plans. The other part of this that we have is to do with providing high quality care, and this was worth 47 points. So this relates to the social prescribing referrals and also that access area mapping exercise that I've just spoken about. So those are where the points are sitting for the current year, and within that there will be various different little indicators that we've got with the various thresholds that are associated with them. So that's what you've got then for the investment and impact fund for the year just gone and the year that we've got coming. Now, looking at what we've had fairly recently, so is the COVID-19 enhanced service. So the PCNs have been the focal point for the COVID vaccination rollout. So within the GP practices, obviously you had to organise yourself into PCN groupings. Now, the guidance for this said that the member practices in the grouping could be different to those within the PCN membership. So, for example, if there was a practice who had not signed up to the PCN, but who'd wanted to participate in the vaccine enhanced service. But in our experience, actually, the PCN groupings followed the main PCN membership that you had. So they were all the same. Within this PCN grouping, the GPs had to nominate a practice to lead the vaccination programme, and they were the ones that got the money for it. Now, when the enhanced service was initially published, it was at the time where we thought that the time gap between the first and the second vaccination was going to be 3 weeks. And although it was going to be £12.58 per vaccine, initially it said that you weren't going to get paid until after the second dose had been administered, at which point you'd have received £25.16, i.e. 2 lots of the £12.58. However, because that changed and the second vaccine was delayed, or postponed really, up to 12 weeks, you now get paid whenever you have administered each vaccine. There was a challenge to trying to get patients who were at home to get vaccinated. And so there was an additional £10 that was paid per home visit, which was on top of the £12.58. And that could have been covered to cover all vaccines administered in patient homes, backdated to December 2020 for that. And obviously now I think you're probably thinking about whether you are going to be involved with the enhanced service for the under 50s, which has obviously been running from April. Now I've heard various things about this. So some PCNs are being involved with that, but others, it's just been found that it's been so taking up an awful lot of your staff time and your premises time as well. Certainly over the last year, you've been incurring a large number of additional costs within the PCN to be able to roll out the vaccine programme. So the staff used is probably a mixture of practice staff. You've got GPs, so your GP partners, locums. Some practices have been able to use volunteer staff. But you've got large amounts of overtime that has been used within those primary care networks. So obviously where you've got staff, the income for them will be effectively pensionable up to their full-time rate that you've got there. Payments for GPs going through the practices are obviously pensionable. And then locums, if they are locuming specifically, doing their A and B forms, then it's going down to whether those A and B forms have been submitted as to whether the income is going to be pensionable there. Potentially, you've had some additional costs in there for premises. So particularly, I'm thinking about where the PCNs are going to be involved with the second phase of the enhanced service, because most practices, I think, have been using one surgery to administer the vaccines. I am aware that some have perhaps used some local minor injury units where they are available. But if you are now needing your clinical space, because obviously the QOF has now started in full from the 1st of April, it is possible that you might be looking at additional alternative premises to be able to run your clinics from for that. So you may be incurring some additional costs there. Now, for the PCNs, and I'll come on to a little bit more about the PCN surplus in a minute, but for the PCN, so as I said, normally the groupings for the PCN are the same as the individual PCN member practices. So I envisage that the money from the COVID will come into the PCN, be part of those PCN accounts, and any related expenditure then sits within that PCN. And as part of that, then each member practice will be reporting their share of the income and the expenses that are associated with that. So this is then bringing me on to looking actually at the PCN surplus, because this is something that we have had some questions on. And the question is normally, well, we've got some additional money that we want to spend. How does this count in towards the surplus? So if we start from the fundamentals of the enhanced service for the PCN, now the PCN is not a separate legal entity. So where you've got effectively a surplus of money, there needs to be a mechanism for that income to be taxed. The PCN enhanced service is linked to your medical services contract. Okay, so your general medical services contract, and it is a requirement of the enhanced service that each member PCN practice has to report their share of the income and the expenditure within their individual accounts. This is irrespective of whether any surplus generated in the PCN has been paid out to them. We quite often get asked about, so where we've got a surplus, to say, well, we've got some money, we've got a bit of a surplus and we want to spend it in the following year. Can we carry the income forward or bring in the expenditure? And the answer is actually going to be dependent on where the income's come from, whether there's any contractual obligation with the expenditure, and whether there's any restrictions on the income as it can be spent. Now, if we take the first year of the enhanced service as an example, the majority of your income that came in was for direct reimbursement, so additional roles reimbursement, clinical director, enhanced extended hours, all gets paid out. The one area of expenditure where you had freedom to spend the money as you wish was your £1.50 per head participation money. Now, because the PCNs were set up quite late, many PCNs didn't really have a chance or an idea about how to spend that £1.50 per head funding. So there was still money sat in the bank at the end of the year. Now, for that year, a lot of PCNs actually paid that out to the member practices. But there are no restrictions on how that money can be spent. So therefore, if you've not spent it, if it creates a surplus, then that's reportable within the accounts. If, on the other hand, the PCN had put in a bid to provide a specific service, for example, if you were doing some kind of health campaign, for example, and so you had to say what you were providing for it, what cost you had associated with it to be able to get the bid money, and then may also be a clause in there that says if you haven't spent that money by a certain period, you need to give it back. If that service had not been delivered in full by the end of the primary care network year, it is possible that you could carry that forward to be matched against the future expenditure. But the difference there is that you have that specific service that you are going to spend the money on. In respect of costs, then you have to effectively have a contractual obligation for the cost to be incurred prior to the year end for it to be included in the account. So, for example, if you have any goods and supplies, for example, so typically things like postage and stationery, so you've put in your order for it, it's been delivered, you haven't paid for it just yet, but you had that obligation to pay for the costs before the end of the year. Other things that would be there would be things typically related to your staff costs, so tax and national insurance. So the obligation to that arises at the end of the year, so you can include that as expenditure within the accounts. So that is where you possibly can and cannot include, make adjustments for various bits of income and expenditure. And obviously the income is pensionable within the individual member practices, and any surplus is taxable then effectively on the individual GPs that you have. So that's how we're dealing with the surpluses.